it's going to be plastics for the next 2 hours. Good. Here's the deal. So I do have some trivia questions in the second talk. I have 2 prizes as well. But that means that you cannot look ahead at the slides in your sheets if you want to play, if you want to try to answer the questions. And if you've heard the trivia question or the talk, because I know a few of you have been before and potentially it's a similar question, refrain from, let somebody else try to answer it first, okay? Deal? All right, so I just need a show of hands. Who does some oculoplastics in their practice? Doesn't have to be all, but just some. That's pretty awesome, actually. I mean, that's the most I've ever had in this group. It's almost a half of you. I'm going to still make this relevant for everyone else because we all are responsible for eyelids and looking at the eyelids and making sure a patient doesn't have a malignant tumor. So this still counts for everyone else. And that's why I really should title this first talk, One More Thing, Doc. Because it doesn't matter what field you practice, you might be doing cornea. And as that patient's walking out of the room and you've just done their refractive surgery, they say, oh, doc, one more thing. This little bump on my eyelid, what do you think it is? That's going to happen to every one of you in this room. So we have to be ready. All right, and the goal is to not to know what every one of these things that they ask us about is. You don't have to. All you have to know is that one on here is malignant, that one. Everything else is benign. I don't care if you know what the other ones are. I just want you to find the malignant ones and then either take care of them or get them to the right person to be taken care of. So I'm going to show you some photos, and I just want you to look at the pictures and just try to see if you see anything on these photos, okay? And I'll give you just a minute just to kind of... Say it? Yep. Lower eyelid, yeah, where? Right here? Yeah, there looks like there's a little bit of maybe lash loss there. What do you see there? Yeah, exactly. Right, there's a little depression or a notch. Getting easier. Okay. Looks like a scar. I heard someone say scar. Yeah. Okay, so what do all these patients have in common? Lower eyelid is true. Most common place to get. They're all fair. You're right. What was that? So it's actually all basal cells. Lash loss, lid architecture changes, irregular borders, telangiectasia, and pearly borders. Those are your buzzwords, right? Ulceration, induration, all of those were basal cells. Everyone. All right, so those are the signs of malignancy in the eyelid. We just went through all those patients, and that's what they look like. And if you can get basal cell, meaning if you get asked a question on a test or a professor asks you a question and the lesion looks malignant, guess basal cell, because it's 90 to 95% of eyelid malignancies. The rest are very uncommon. It's basal cell most of the time. This patient really struck home with me. She's 23 when she came and saw me. She had just graduated from college. She was a teacher. And she said, I noticed this little eyelid lesion on my upper eyelid. What do you think it is? Like, one more thing, doc. What do you think it is? I thought it was benign because this one does not have any of those features we just talked about. It's not destroying natural eyelid architecture. So I said, let's photograph it, and I'll see you in 6 months. We'll make sure it doesn't change. She came back like 2 weeks later, and she was like, it just doesn't belong there. Can you just take it off? So I did. It came back as a basal cell, 23-year-old. Very fair, but still 23. So I just want to make sure you get the point that this is happening in young patients now too. I diagnose a lot of 30-year-olds with basal cell. She was the youngest. And so we did, the removal and the reconstruction, the post-op reconstruction. Mostly on the reconstruction here, we're trying to avoid the lashes changing in their direction because she's got a nice lash line. We don't want to alter the way the lashes look. So if we think about this by way of anatomy, we have the skin in the epidermis and then the dermis, right? That's the deeper layer. And in the epidermis, we have squamous cells that create squamous cell carcinoma. They're the superficial cells. And there's a reason that's important. That's why the squamous cells desquamate or create keratin, and they can be flaky or crusty because they're that superficial layer of cells. It's also why pathologically they have keratin pearls. So all this stuff makes sense from an anatomic perspective. The basal cells are the next layer, and then melanomas and the base of the epidermis come from the melanocytes. If we go deeper into the dermis, we have the dermal appendages, and that's where we can get sebaceous glands and sebaceous cell carcinoma. So we can think about this anatomically. You guys all mentioned this when I said what's common about all those patients. I heard fair skin, they have actinic damage, UV exposure. Those are the risk factors. And the lower lid also is much more common than the upper lid and the medial canthus. Upper lid is least common. Why? Yeah, because of the brow. The brow's blocking the sun. There was a really interesting study that came out of Duke maybe 5 or 10 years ago. They did some sort of I don't know if it was a black light, but they used some sort of a light that could detect where people put sunscreen. And they said to people, put sunscreen on your face. And then they did the test, and people they don't get it on their eyelids. How often are you rubbing the sunscreen on your eyelids? No, nobody does, right? So plus it stings. So that's why we see these so commonly. There's different subtypes. If your pathologist is able to subtype these for you, it's helpful because nodular is relatively benign, but a few of these, infiltrating, morpheaform, and basosquamous, are a little bit more aggressive. And the reason is, if you look at one like this, it's hard to tell where it starts and ends. So as you resect one of these tumors, you're going to wind up with a bigger defect than you expected because it's going to extend in places that you maybe didn't quite expect it to. Okay, so does this one look benign or malignant? Totally, right? I mean, what are the things that make you think it's malignant? You guys you're so good. I think everyone answered. It's amazing. I saw people saying lash loss. I saw people indicating kind of that notch in the eyelid. It's destroying natural eyelid architecture. That's the key point. This one turned out to be a squamous cell. The one I showed you on the first slide was also squamous cell. It has keratinization. So when you see keratinization, you want to be a little suspicious about squamous cell, again, because it comes from the superficial layer of the skin cells. Here's a case for you. This is an 80-year-old guy. He came in with some proptosis, some pain on the right side, hypoesthesia in V1. He had some limited motility, and he had a little bit of an optic neuropathy on the right side. And if you look at his imaging, he has this heterogeneous lesion that's pretty well circumscribed in the superior orbit. And when the neuroradiologist read this, and just like Kyle's talk yesterday, his most common things, schwannoma is what they told us. This is a schwannoma of one of the nerves sitting in the superior aspect of the orbit. Great, so we take him to the OR to take out this schwannoma, and it's stuck to everything. Turns out, because we couldn't really get it out in one piece, we sent frozen section, and they said it's squamous cell, it's invasive squamous cell carcinoma. So what happened was, this is perineural spread of squamous cell. When we asked this gentleman after we woke him up from the surgery, do you have a history of squamous cell? He said no. And then when he came back for his 1-week post-op, he said, actually I was thinking about it. I've been seeing a dermatologist for many, many years, and he's always burning stuff off of my face, but he doesn't send anything for pathology. So obviously, one of those lesions was a squamous cell. And the reason I show this case is to remind you that squamous cell is more aggressive than basal cell, and it can have perineural invasion. When that happens, in this poor gentleman's case, he passed from this disease because it went back to his brain through the nerve transmission. So who in your country utilizes Mohs surgery for skin cancer? I saw one. Yeah? But not you. But like patients can get it if they want it. Okay. Yeah, a few of you. So Mohs surgery is a dermatologic technique to remove skin cancer, specialized training, and the big difference with Mohs surgery is the way that they section the tissue. They're able to have a slightly higher success rate than just doing a frozen section or a wide resection, and they're able to remove the least amount of tissue possible. For us in the States, 99% of patients get Mohs surgery, but I recognize that in many of your countries, it may not be available, and you may wind up doing frozen section control, meaning you go to the operating room, you cut out what you see as the tumor with your eyes or with your microscope or whatever, and then you send the sides, basically the margins. You send the lateral, the medial, the inferior, the deep margin for a frozen section, and you wait, and then hopefully your pathologist says it's negative, and then you fix the defect. And that's fine too. It still has pretty high success rate, 95 to 97%, so not bad. Here's a guy who came in. We diagnosed him with basal cell, a little subtle. He has a little bit of lid notching and lash loss medially. Had a defect that looked like this. This one involved the canaliculus, so we had to repair the canaliculus. We did a Tenzel flap, I think, for him, like a little flap out here, brought everything this way. And you can see him a year later, looking good. He was do you guys know what the word curmudgeon means? Anybody? Curmudgeon's a fun word in English. Curmudgeon is like a grumpy old person. A curmudgeon. He was a curmudgeon. Just never happy, never quite satisfied. But anyhow, I don't blame him because a year later he came back to me and he looked like this. So what do you think? Maybe. She said was not fully excised. Possible, but recurrence is a risk. And so the reason I show this case is to remind you that even once you've taken care of one of these patients with skin cancer, you should still bring them back. What I do is I bring them back every 6 months for the first couple of years. I watch for recurrence. And then if they're good, then I just bring them back annually for a routine check. But I make sure they see dermatology every 6 months or so for a full skin check. Because once they've had a skin cancer, they're at risk for more skin cancers. We'll talk a little bit about pigmented lesions. This is a benign pigmented lesion. One of the reasons, like a lot of patients are going to come in with these pigmented lesions on the lids. You've probably all seen them. Some of us probably have them. And the lashes grow through them. That's a great sign that it's benign. The patients also will say, I've had it my whole life. That when they say that, you can usually be not so worried. They have regular size, and really the biggest one is that they're not destroying eyelid architecture, and the patients usually tell you, I've had this thing like my whole life, so it's not a worry. But we want to worry about things if the color changes, if they're large in size, if there's asymmetry of the color, because then you might want to start thinking about melanoma. Obviously, this is terrible looking. But I wanted to show you a way that you can manage melanoma if you have to in your office, and that's by way of something called the square procedure. This was actually a paper written by Hakan Demirci in University of Michigan. And Hakan is a phenomenal tumor specialist in the States and a wonderful guy as well. And his paper described this square procedure. So this patient shows up to your office with this pigmented lesion. It's got multiple areas, there's color ambiguity, so it doesn't look good at the beginning, right? You're suspicious. When it comes to an eyelid lesion that's pigmented, it's totally fine to do an incisional biopsy. You can cut a small piece of it and send it to pathology. Because if it's melanoma, we're now talking about a very wide resection, and for most people, if it's melanoma in an eyelid, you're taking like their whole eyelid off. So you don't want to do that and find out it was benign. So you can do an incisional biopsy. You find out it's melanoma. We now know this is melanoma. How do we manage it? Well, you take the patient to your office, and you basically make a geometric figure around what you think is the melanoma. And you cut these strips out, and you send them to pathology, and then you put stitches in. So it's going to look like this after your first procedure, okay? And then you send the patient home, because melanoma, frozen section's not good. It's not accurate. So you need to give the pathologist time to look at the tissue. And so you send the patient home. The pathologist comes back to you and says, this, and this are good. I don't see any melanoma. Here, I see melanoma. Okay, no problem. Bring the patient back, go out further, take another strip, send it to the pathologist, sew it up. Pathologist comes back to you and says, no melanoma anymore. Here, great. Now you can take the patient to the operating room and you're going to resect all of this. And you have at least a margin control on the melanoma. So that's called the square procedure. It's a great procedure for managing more malignant types of tumors that can't be used with frozen sections. So a really good procedure. Now, sebaceous cell carcinoma is really what I consider to be the great masquerader. You want to be suspicious of it. I've only seen, honestly, a few cases in my whole career. I've been doing this now for like 15 years as an attending, and I've only seen a handful. So it's not common. This is a terrible picture, but she had sebaceous cell. But basically, anybody who has kind of recurrent chalasia, yellowish tissue in the lid, unilateral blepharitis, when we see like meibomian gland dysfunction and blepharitis, it's usually on both sides. If it's like really just evident in one area of an eyelid, think about sebaceous cell and just send pathology. It's that simple. If this is the third chalasia this patient's had in that location and you're going to drain it, just send it to pathology and make sure. It's easy. So that's it. So these are the big four. And that's all I care about for you, is just to be able to recognize squamous cell, basal cell, melanoma, and sebaceous cell, and know those features of malignancy in the eyelid. And it's perfect timing. Anybody go to the Mirabelle Gardens yet in town? The flowers? The tulips are like about to bloom. It's really it's worth the walk for sure. But here's your mnemonic tulip. So this is our spring mnemonic for eyelid malignancy. These are the things you're looking for to try to rule out malignancy. And if you see any of those, just take a biopsy. I tell our residents, when there's an issue, get tissue. So just take a piece of the tissue and send it, and you'll know, okay? Questions on this before I move on to reconstruction? Yeah. Right away. That's interesting, and that's great. I think we do something similar in the sense that if we really are convinced this is a malignant appearing lesion, we might skip the incisional biopsy. But I will tell you, like at least in my clinical practice, 99% of the pigmented lesions that I biopsy because a patient says it's new and they're not sure, they come back benign, and they would involve, as you know, like a pretty wide excision, some of these, to remove them. Especially if you know it's a melanoma, you're going to want to have a wide margin. So we still do an incisional biopsy. But I agree that the classic teaching with melanoma, especially anywhere else on the body, is that an incisional biopsy is not indicated because you don't want to increase the risk for tumor spread. So yeah, it's probably a point that maybe people debate. But that's how we manage it in the States. Yeah. Yeah, which one? Which one? Oh, the square? Oh, sorry. Yeah.
So, this is a big area. Where is it better to take the biopsy from?
Oh, yeah. Where's the best place to take a biopsy? So that's a great question. And actually, for any lesion that you're concerned about, when you do a biopsy to just make a diagnosis, it could be that you're thinking about basal cell as well, right? the pathologists love to get interface tissue. So they love to have, and they don't necessarily like need or want like the middle here where it's like totally looks pigmented. They like to see the transition. So they almost would probably love like a little piece here where you've got some of the pigmented, some of the unpigmented, so they can see how the cells have transitioned. So that's the place, is that transition zone, but you obviously have to get some of the weird appearing tissue. You can't just get benign tissue or you'll miss the diagnosis, but they'd love to see the transition.
So these is free graft here, or what?
So this is prior to the resection. This is just making sure the margins are negative. But once the resection happens, all of this tissue is going to be gone. And so then you're going to have to reconstruct, and I'm going to talk about some reconstruction techniques next. In a case like this, you're probably doing a skin graft because that's a pretty big defect you're going to get. And I don't know that flaps would cover it, but I'm going to show you some defects in a minute.
Right now in this picture,
This is still the melanoma. Yeah, this is all you've removed are little strips on the edges, but you see pigment and pigment and pigment. All the melanoma's here.
just you cut it.
On the sides. All you're caring about right with the square procedure at the beginning is the margins, the edge. Yeah, it's cool. It's pretty cool. Yeah, Hakan's a smart guy. Yeah. Yeah. Yeah, that's a great question. High versus low risk melanoma. We're so lucky where we work because we're very subspecialized. And so when we have patients like that, we actually have a dermatologist who's a melanoma expert. And so we're working in coordination with her to make sure the patients are followed appropriately. So she's more the person doing that. But I will say for melanoma and for sebaceous cell carcinoma, we also work with head and neck surgery, and we do sentinel node biopsy. We do lymph node dissection on those patients for whatever the draining lymph nodes would be to that area of the eyelid, so that we can test the lymph nodes at the time of surgery and find out if there's lymph node positivity, which then does direct potential future care, whether it be a chemotherapy or something like that if they need it, if their lymph nodes are positive. With sebaceous cell and melanoma. Yeah, yes. Back further? This one? Yeah? Yeah?
But now you know what to incision. But wouldn't you have to take more? Because right now, if you would just incision that, the histology would say you're not healthy. You know what I mean?
Yeah, you do. You take a little bit more than this. So basically, when you go to resect, like if you're making your incisions, it's going to look like something like this. Something like that. Yeah. Yes. Yeah. Mm-hmm.
The very few patients that we see with basal cell carcinoma are Malignancies.
It's a great point that you're making. Our friend from Tanzania is making a point that he does, in case you couldn't hear him, that he doesn't see a lot of basal cell, he sees a lot of squamous cell. And I think that geographic tendency is a super point because you're seeing squamous cell for two reasons, really mainly immunosuppression. So patients who are immunosuppressed, he mentioned seroconversion, HIV positivity, but also in transplant patients, squamous cell carcinoma is much more common who are on immunosuppression. And also, I'm going to guess that most of your patients are have pigmented skin, and they're less likely to get basal cell carcinoma for sure. So that's totally a geographic thing, and that's a great point that you're making. I think for you, makes total sense where you're practicing. For folks who are practicing, like, in Mexico, you're going to see a ton of basal cell carcinomas in Mexico because of the sun exposure and that sort of stuff. Yeah, great point. Yeah. Yes?
I'm just wondering if you follow surgery for nodular type of basal cell carcinoma.
Yeah, that's a really good question. Do I do Mohs surgery for nodular basal cell? And it's the one that I am willing to kind of go either way depending on the patient preference. Because nodular's usually really easy to see. It looks like a nodule. You can really see the edge as well. So if a patient doesn't want to have two separate settings of surgery, for Mohs surgery, they have to have the Mohs on like day 1. They put a patch over the defect, and on day 2, they see me for the reconstruction. Sometimes we'll have like an older patient where it's much easier just to take them to the OR one time, do like a wedge resection, send frozen sections, close it, and they're like one-stop shopping. So yes, for a nodular, I'll consider it. It's a really good point. Yeah. You guys are awesome, man. I just so great. All right, so let's talk a little bit about reconstruction. I'll show you a few things that I've learned over the years with that, and just checking our time, make sure we're doing okay. Okay. So the usual suspects, we've already talked about them, right? The basal cell, squamous cell, melanoma, and sebaceous cell. And have you all seen this movie, Forrest Gump? Right? So life is like a box of chocolates. You never know what you get, right? That's the Mohs defect, right? That's your eyelid defect. They come in with a patch, and you pull the patch off, and you're like, ooh, man, So it could be, small, medium, large, extra large. Like, you just don't know until that resection happens. You do have a good idea based on the first look at, what the tumor looked like. So the ones that might wind up being bigger. But I'm going to talk to you about a few techniques to avoid this complication, which is cicatricial lower eyelid retraction. The lower lid's the hardest part. The medial aspect of the lower lid also, I think, is the hardest part to reconstruct without getting ectropion. And this patient had a skin graft, and obviously, either the skin graft wasn't big enough or the lower lid needed to be tightened at the time of the procedure. So this is hard to fix. Let's try to avoid that complication. So I consider this defect like the oculoplastics version of temptation. Because don't you just want to close this thing like regular, like just a few stitches? Yeah, why not? Guess what? 90% of the time, it'll be fine. But a small percentage, you're going to get an ectropion, and you're not going to like it, and the patient's not going to like it. So I challenge you to not be tempted on these cases and to actually make a case out of it. So how do you make a case out of it? Well, you basically can do subciliary incisions, and you can close this not with vertical tension, but with horizontal tension. It's going to heal great, and you're going to minimize the chance for an ectropion because you've changed the tension from vertical to horizontal. So basically, this is her post-op, and you can see no ectropion. Now granted, if I had closed it primarily, I still might have gotten lucky, but I don't want to risk it. I don't want to chance it. In older patients, you have to be even more mindful because they have some laxity potentially to the lower lid. And so in a patient like this, I'll do one more thing. I'll extend my incision out laterally, and I'll do like a canthopexy stitch out here with like a PDS suture, like a long-acting dissolvable suture, just to basically anchor the lower lid so that it has some horizontal tension to it. And you can see post-op again. The subciliary incisions heal, you can't even see them. So it's a perfect place to make an incision if you need to. This is me stretching. No, it's not me stretching, I'm just kidding. But I do this stitch all the time. This is actually post-fracture case, but it's a stretch stitch. Do you all know about stretch stitches or frost sutures? They're really helpful for these. I do them whenever I think of them. Here's an example when I would think of it. This patient had thyroid eye disease. She had a nodular basal cell carcinoma, actually. I think I don't remember if I did her under frozen section or not, but this is the defect. So she's got like a 50% defect of her lower lid, maybe 40. And so what we did for her is we did a canthotomy and a cantholysis. We closed this, but I put a frost stitch in, which basically means I put a stitch from the lower eyelid through the upper eyelid, through the brow, and I stretched the lid up for a week after surgery. Patients do hate these stitches. They're uncomfortable, they look terrible, but they really help. You can see right after removing the stitch, if you look really closely, you can see the indentation that it had made in her brow. But it helps to stretch the lid up to prevent that retraction. And this is a patient who's prone to retraction because she's got that history of thyroid eye disease, so she's prone to retraction. And post-op, lid stayed in good position. So I think the stretch stitches help, and when you have a lid that has closed in a tight fashion, maybe you just were able to get it closed, stretch the lid for a week. I think you'll save yourself some troubles. Okay, like when you see a tumor like this, you're prepared that you're going to have a bigger defect, right? So here's the defect, pretty good sized defect, tough location, medial aspect of the eyelid. What are some techniques you can use to close? What kind of flap? You could do a glabellar flap. That's actually true. You definitely could. It's going to be a little thick in that location, but you can do a glabellar flap there. Here's what I do a lot of the time with these. The point I'm going to make is anchoring your flaps to the periosteum. So basically, you're not just closing skin once you get to these bigger defects, but you need to get periosteal bites to hold that flap up. But what I do a lot of times is I'll do a subciliary to like a modified Tenzel flap, and I'll recruit all this tissue, and then I'll do a nasolabial fold incision, and I'll recruit all this tissue. And we'll bring it up and in, but the key is that you're going to have sutures under the skin to the orbital periosteum, again, to anchor the flap up so that the skin's not under tension, the flap's being held up by deep sutures that last, usually I use, again, PDS suture, so it's like a 6-month dissolving suture, but you can take your pick on what type of suture you use there. And then I'll do a frost stitch. So this is the frost stitch here, you can see it. Looks terrible, right? I mean, this is the patient a week after, and you're like, man, what's gonna happen? But they really heal well. And the key here is that if you look at the lower lid position medially, I would argue, if anything, this lower lid might be higher medially than that one, the one we operated on. And what we're trying to avoid, which is so easy to get, is that medial ectropion. So easy to get. And even doing all this stuff, I've gotten them before. So you really have to like pull, as we say, like slang sort of, but we say pull out all the stops. Like do every trick you have to try to get that lid to stay where it belongs. This is a good article. It's by Vic Elner. It's called an Eyelid pedicle flap. And these are helpful also for these medial defects. Like this one, I used an Eyelid pedicle flap on. I'm going to show you what that means. I did the same thing. I did that subciliary incision to recruit tissue up and in and anchor it to the orbital periosteum. But the Eyelid pedicle flap is an incision like this. And basically what you do is you dissect that tissue, but you leave some of the vascular supply attached to it. And then you bring it up. So what happens is this piece here kind of comes up to here. And the cool thing is two things. It has vascular supply, so it's not like a skin graft because you've kept the central kind of stuff attached to it and you've brought it up. But the big reason this thing helps is because when you close here like this, it's almost like a support. As you close that below, it's pushing everything up. So it acts like a support beneath. And that really allows that medial aspect of the lid to stay in place. I did a tarsal strip on her and obviously a frost suture, but you can see post-op. Again, I think that the medial aspect of the lid, if anything, it might be higher than her non-operated side. And so that's fine. Like I'll take that any day of the week if I can get it. So when we see these patients, what we do is we really explain to them that there's 3 main goals. The first goal is definitively remove all the tumor. And I can't control how far that tumor went. So patients are like, am I gonna have a scar? It's like, yeah, you're probably gonna have a scar, but like we have to get the tumor out first. The second goal is, let's make sure your eyeball works. Like if we get that cicatricial retraction that I showed you, that guy's eyes are gonna be dry, red, irritated. He's not gonna see very well. So let's make sure we put the lid back in a way that it closes, that it doesn't have an ectropion. And then obviously third, we want them to look as good as we can make them look. And I do tell patients that there's always things we can do later. If a patient doesn't heal the way you want, which happens all the time, you can work with your dermatology colleagues. You can do lasers and peels. You can do a surgical revision if you need to. This patient had a Hughes procedure for a pretty big lower lid defect. Very nice lady. She was a renal transplant patient, so I think it was a squamous cell in her. So these immunosuppressants, again, can get squamous cells more commonly. And she healed great. And I think she had a skin graft. So Hughes procedure, borrow tissue and then a skin graft on top. And I've found over time, incidentally, that patients who are on immunosuppression tend to do, they look better after skin grafts because I think that they don't kind of get that hypertrophy and that big inflammatory response to a graft. So she did really well. So take home points, respect the lower lid. Gravity wins. Gravity always wins. So just do everything you can to try to beat it. And so avoid vertical tension, reorient to allow for horizontal closure of eyelids. If you think that you've closed an eyelid and it's tight, or it wants to pull down for some reason, sometimes we call that bowstringing. Like if you do a wedge and you're closing the eyelid margin, and a patient has a prominent eye, or sometimes we call a negative vector when the cheekbone sits back, and the lid wants to loop down below the eyeball, we call that bowstringing. If you start to see a hint of that as you close, put a frost or a stretch stitch in, because it'll help you prevent that bowstringing. Don't forget to support bigger flaps with deeper tissue. Even if you do a glabellar flap, you should put some deep tissue, deep sutures into the periosteum. And then those island pedicle flaps, it's in your notes, but if you read that paper, it's pretty descriptive. It's a really good procedure for your medial defects that are big, and it's a strong procedure, so it'll help prevent retraction. That's what I got. Any thoughts or questions?